Thank you. Well, thank you very much for the kind invitation to come and speak at this excellent meeting. Quite unusual, I don't know very much about microinfarcts, and normally I can't see them either, so it's slightly unusual giving a talk about something which I know nothing about and can't see. However, I thought I would try and tell you something of what I know. Much of this information comes from two review articles that were published last year, listed here. I would recommend both of them to you. They're very good summaries of what we know. Microinfarcts are defined as being microscopic, i.e. not visible to the naked eye, or little tiny foci with neuronal loss, gliosis, pallor, or cysts, or sharply demarcated microscopic ischemic lesions. And these are a couple of examples. They can be cavitated, they can be non-cavitated. And they've been reasonably widely studied in the pathology literature. I thought I'd summarize a little bit about what we know about where they are and how big they are. They seem to affect all brain regions, but they seem to mainly affect the cortex, although it did occur to me that it might be because they've actually been studied most in the cortex, and perhaps people have looked less in other areas. But certainly they seem to be common in the cortex. They may occur more frequently in arterial border zone regions in the cortex, but the problem is that many studies that have published on this did not compare different brain regions. And if you think about it, it would actually be quite difficult to do this. These are tiny things. You have to look microscopically. You'd have to sample very structured sort of way. So studies are ongoing at the moment on that, but perhaps our perception that they're mostly cortical is because that's where people have mostly looked. The consensus as to how big they are also varies rather a lot, somewhere between about 50 microns and 400 microns, although some studies talk about a few millimeters, and it has been suggested that cystic ones might be slightly larger than non-cystic ones. These may all reflect measurement, processing methods, who knows. They are quite common and are clearly associated with increasing age. So this slide is taken from a couple of different sources. One is from the review article by Geert van Biesel's group published last year, where they summarized a number of pathology studies, and I've highlighted one of those pathology studies because it was a particularly large study and it was very useful. But it looks as though that amongst over 1,000 non-demented older control subjects, there was quite a wide range of microinfarcts. In two large databases which look specifically at people over the age of 65, the people who were classified as being normal, not normal when they died, but were not affected by either Alzheimer's disease or vascular dementia, the prevalence ranged between about 20%, 16%, slightly more common in men than women, maybe. In the group classed as having Alzheimer's disease, they were said 43% were said to have them, but look at how the numbers are starting to decline, fewer studies and fewer subjects. And they were supposed to be even more common in vascular dementia, 62%, but only 87 patients were in that category. So really the evidence starts to become less reliable at these extremes. This graph is from the study of Longstreth, the large neuropathology study I highlighted, just showing how the prevalence of microinfarcts increases with age in this large neuropathology database, even up to quite high ages, 95 plus, and quite respectable numbers here across the whole database. So clearly an age-related phenomenon. And this is from the other systematic review, which I mentioned from last year, looking at the association with cognition. And it's quite clear that having microinfarcts is associated with being more likely to be cognitively impaired or formally diagnosed with dementia in life. And this is in community-based cohorts. This was trying to pick out the cohorts that had particularly good and reliable sampling and weren't just picking out people who had died specifically of Alzheimer's disease. But having microinfarcts seemed to more than double your risk of having dementia. What about risk factors? Well, apart from age, it's a little bit unclear. It's a bit surprising, but there seem to be rather mixed associations with hypertension. There was one suggestion that they might be associated with hypertension in people under the age of 80, but not over the age of 80, and perhaps just because age catches up with you. But clearly more information is needed on that subject. There was no clear gender bias in any of the other studies, and there was no clear association with any of the other common vascular risk factors in any of the other studies, but that may reflect ways of collecting the information. Pathologically, they are associated with having a cerebral amyloid angiopathy burden. They're also found in people with lots of arteriolosclerosis. They're found in CADASIL, and they commonly coexist with degenerative pathologies. But these are all things which get more common, with the exception of CADASIL, as we all get older. So perhaps we're just seeing co-associations rather than distinct associations, and clearly more information is needed. These are supposed to be very hard, if not impossible, to see on routine MR imaging, which would be normally at 1.5 or 3T. And most things are very hard to see if they're very small, unless they have a very, very bright signal. So it's been suggested that the obvious way to study these would be to start with very high field strength scanners, looking for areas of cysts or rarefaction, looking specifically in the cortex. And it's possible, it occurred to me when I was looking at this last year, that some perivascular spaces that we think are perivascular spaces might actually be microinfarcts. But anyway, the next few slides, sorry. So the point is that in routine imaging, if they're very difficult to see because they're so tiny, might it be possible to detect their presence because they're associated with other things which we can see? And so this is also from the Longstreth paper from a couple of years ago, looking at associations of microinfarcts in pathology data. Now, this is not imaging data, this is pathology data, but the more microinfarcts you had, the more likely you were to have macroinfarcts. The majority of these were actually lacunar, small subcortical infarcts, white matter hyperintensities, or have hemorrhage. And in the other database that they looked at, there was also the association with macroinfarcts. So quite consistent associations with having more features that we would associate with being classed as small vessel disease. So the more small vessel disease you have, the higher the chances that you are harboring some microinfarcts. It's also been suggested that some of these small diffusion-weighted, is it possible to put the lights down? Which have been reported asymptomatic lesions in patients presenting with hemorrhage. This is from the Boston group, noting small hyperintense DWI lesions, and perhaps if these build up over time, they can leave little scars which pathologists see as microinfarcts. Similarly, in patients with small vessel disease, little tiny dots which may build up over time and leave scars at death seen as microinfarcts. We don't know. We don't have enough consistent information. You'll mostly, I guess, be familiar with this case report from a couple of years ago from the group here on a 53-year-old male patient with CADASIL who died in his 50s after having a fairly typical history and having had sequential MR imaging in life, and agreed to donate his brain for the purposes of study, which included having post-mortem MR imaging at low and high resolution and pathology. And these were his MR scans in life, for his typical appearance, white matter hyperintensities, small deep holes, lacunes, both scans, and you can see how it was gradually getting worse. And then here at the post-mortem examination, you can actually see these little things in the cortex, which are the microinfarcts, even at the low resolution. And here it is on pathology. So these can be demonstrated using high-resolution post-mortem MR. The question then is, well, can we actually see those in life? I would just also point out some other features here. These are what we would interpret as being perivascular spaces, so quite closely related sometimes to the subcortical tissues. So this is from the Van Biesel's group, John Wiesel's group in Utrecht. I'm very grateful to him for these slides. This was published last year, looking at a group of patients who died with Alzheimer's disease, where they looked very carefully on post-mortem MR imaging at 7 Tesla and found little lesions in the cortex, which they confirmed were microinfarcts on pathology. And they then went in to examine a series of older independent subjects who were actually not particularly old, and scanned in vivo. And of those 22, found 15 with what they thought were probable microinfarcts, 15 probable microinfarcts in 6 of the subjects. And here are some examples. So this is a sagittal view, and you can see a little dot on the FLAIR image, little blow-up pictures here, little tiny things in the cortex. And another couple of examples, again, high definition FLAIR imaging at 7 Tesla, little tiny things sitting in the cortex. And you obviously have to look very, very closely to be able to see them. They're more visible on the T2 and the FLAIR than they are on the T1, where they appear dark. And here's one where they thought it might have been a more recent example, little one sitting out in the cortex, and there it is again. So quite clearly capable of detecting them on 7T MRI, and they summarize that by saying that these lesions were hyperintense on FLAIR and T2 and low intensity on T1, and that they would be detectable if they were more than 0.5 of a millimeter in diameter in life, and you could probably detect them if they're over a millimeter clinical resolution. Anyway, so here I was sitting during the week thinking, oh my goodness, what am I going to say at this talk on Friday when I know absolutely nothing about microinfarcts, and I don't think I've ever seen one. And I have to look at the scans of a lot of much older people. And this is somebody from our Lothian birth cohort 1921 who's now aged 91 coming back for repeat scanning. And I thought, well, if you're supposed to be able to see these in the presence of lots of other features of small vessel disease, why don't I just look a bit harder and maybe I'll be able to see something? So sure enough, I was sort of fishing away, and I looked at the extreme sagittal view, and if you look very closely, there's a little blip just there, there's another one there, and there's another one there. I thought, oh my goodness, and looked a bit more closely, and I also noticed, and you probably can't see these very well because of the light, but there's also some perivascular spaces just coming up towards you, little round dots in cross-section coming towards the cortex. And I looked very hard on the other sequences. We have a number of other sequences, and they were extremely difficult to see on the T1 because, of course, they're dark on a dark background, and the eye doesn't appreciate that very well. But anyway, here's a more magnified view. There's that little thing. It looks rather like those little things that were being picked up on the 7T scanner, just not quite so crisp. But sure enough, on closer evaluation, there's a little block sitting there, and there's a little tiny one sitting there. And so I sort of thought, well, after all, maybe we can see these at 1.5T. That's a millimeter, that scale there. Sorry, it's red, you probably can't see it. And the little microinfarct sitting next to it. That there is a centimeter, and that's a millimeter. So it gives you some idea of the scale and the precision that you can actually get with a reasonably well-tuned research focused 1.5 TMR scanner. There's the perivascular space. So it's not all lost. It is worth looking, and perhaps we can see these even at lower field, and perhaps that means we can study them in life. So just to summarize, what do we know about these? Well, they're common with advancing age. They're associated with macroscopic and microscopic evidence of small vessel disease, amyloid angiopathy, and CADASIL. They're less defined in terms of their associations with usual vascular risk factors, and they are visible even on close scrutiny. Even at 1.5T, at least 3 of them are. So I would encourage you strongly not to give up. Future directions, what should we do? Well, I think we need to have much closer in vivo post-mortem histopathological correlation for these, but also other features of small vessel disease. We really don't know as much about these pathologically as we should. We need to look at their distribution, risk factors, tighten up on some of the macroscopic imaging associations, perhaps just tidy up the terminology a little bit. And are they really distinct, or is this just a tiny vessel version of the small vessel diseases that we've been talking about for the last couple of days? And I rather suspect that this is just a question of scale, and why, I don't know, but perhaps these vascular diseases pick out some vessels first, and then gradually, as you get a bigger burden, they start picking on the little tiny ones. I don't know, but that's my summary.